Good morning, everyone. I'll do my presentation in English. And thank you for the presentation. I work together with Margarita, Alice, and Gaia at NRRP, mostly on the in vivo models. And today I'm going to show you the in vivo model we use to test the two different modalities of radiotherapy. Can I? Ecco. Okay. So Alice previously talked about using melanoma cells. So we specifically use the murine cells of melanoma and we inject them intradermally on the leg of the animal. This protocol by now is very much standardized. So we know that 5 days after injection, we are able to see a small tumor. And then at 12 days, animals reach the maximum volume. And at this point, they are obviously euthanized. We then follow a longitudinal approach. So we are interested in irradiating the tumor at day 5, very early. We do different groups of animals using the different modalities. So FLASH, conventional, and then we obviously have a group of animals that are non-irradiated. And then we follow them every week, measuring different parameters, with the main goal of comparing the efficacy of FLASH and conventional therapy. And one of the topics that I'm going to talk about today is the control that it has on tumor growth. So if it's able to reduce tumor growth or not, and if there's actually a difference between the different modalities. So when I think of tumor growth, I think all of us, we think about increase in tumor volume, right? And doing a very quick search on literature, you find that this is a very simple way of doing, but actually one of the most commonly used ways of measuring tumor volume. And it makes sense because you use a caliper, you use the equation of the volume of an ellipsoid, and you do a rough approximation. And it's quite easy to do if, like us, you use a model of a solid tumor on the surface of the skin. Now, this is also easy to upgrade, and at NRRP, we actually have an ultrasound system. And using an ultrasound system, you can be much more precise, measuring the tumor volume and the tumor area and distinguish it from the skin and the muscle surrounding it. And so we have a system where basically we use, this is what we call a transducer. We position it on the leg of the animal without the fur and in contact with a gel that helps conduction. And basically it scans the leg of the animal doing multiple acquisitions. And in the end, you are not only able to do a 3D reconstruction, but in each of these sections, I can, in a very precise way, define the region of the tumor. This is how we calculate the volumes. Again, this protocol is quite standardized by now, and we've done it in 2 different groups of animals that we treated with a dose of 19 gray, and the other group of animals treated with 35 gray. So far, we don't really find a difference between groups. The very obvious difference is that despite or regardless of the kind of radiotherapy you use, it definitely slows down tumor growth when compared to control animals. Now, this also led us to think that if there were other informations that we could take using this technique, because we know that tumor growth is also associated with a high angiogenic activity. And actually using ultrasound, you can detect that movement that is usually associated with blood flow that literally comes in the direction of the transducer, so perpendicular to the transducer. And what you see here in red, these hot spots, let's call it like that, are most probably major vessels that surround the tumor and are inside of the tumor. Now, this is nice. You have an overview of the angiogenic net surrounding the tumor. But the problem with using this power Doppler, which is the setup we use to do this acquisition, is that it's quite variable with the position of how you put the transducer. So you can imagine the tumor grows, and then every week we go and do this acquisition, we also are not sure to be exactly at the same spot, right? So a way of working around this is using what we call contrast-enhanced ultrasound, which is nothing less than using these special bubbles that are very, very small, and they are made of an inert gas with a shell of phospholipids, and they not only have a very special acoustic and mechanic properties, which means that either if you change the position of transducer or not, you will always get the same signal intensity, and this is important. It was what we were trying to solve, but they enter the bloodstream, and they not only obviously pass the big vessels, but they arrive to the capillary vessels. So we get a lot more information on actually the vasculature probably inside of the tumor that we expect to have smaller caliber vessels, right? So because I'm very lucky and I work with a group of people that are very specialists at doing this, they allowed me to put this idea in place. And now, for example, initially it was very helpful because I'm going to tell you that this is the tumor. And right now you just have to trust me that this is the tumor because I have a lot of experience looking at this, okay? But actually, when we use the microbubbles, so the leg of the animal, this part here is the bone, these are different muscles, and this is the tumor. I inject the microbubbles on the tail vein of the rat, and then if we wait a little bit, as I said previously, I expect them to see arriving here at some point because I expect this area of the initial growing tumor to be highly angiogenic. And here they are. In comparison with the rest of the tissues, they arrive here. So this gives me some confirmation that the tumor actually exists. This is the same animal 12 days after. Again, here you can more clearly see that the tumor is here. We do the same protocol and they should arrive here at some point. And in this particular case, they are pretty homogeneous. So they are equally distributed. They seem to arrive to the whole area of the tumor surface, right? Okay. Now, if I keep following the same animal, at this time, the tumor volume basically duplicated. As you see, it's huge. Using the same protocol and injecting the microbubbles, you see that they arrive firstly here, which probably means you have a bigger vessel here, and then they take longer to arrive to the other part of the tumors. And actually, this part that you can see here in black probably does not have a blood supply. So it's what we commonly call a necrotic area that are common to find on these kind of tumors. Now, I'm not going to go into detail, but obviously I'm not doing this just to show you the cool images. I'm showing you this also because this is pretty much quantifiable, and you usually get a curve like this, and different parameters of the curve are associated with aspects of blood volume and blood perfusion that arrive to the area of the tumor. And not only in our particular case for now, we are using it to monitor angiogenic activity and vasculature on following up these tumors. But actually, microbubbles have been around for a while. They are commercialized in Europe and also in the United States. And right now, there has been an increasing interest on using them coupled to other techniques. And for example, one interesting application that we found is that using these microbubbles together with ultrasound can increase the antivascular effect of radiation. I don't know if I still have time. Okay. But basically what happens is that when you put an ultrasound input of these microbubbles, they do a thing called cavitation. So they expand and contract. They do it very quickly. And when they do it inside of small capillaries, they disturb the endothelial cells. And so some in vivo studies have been proving that actually coupling these mechanical disturbance on the vessels with radiotherapy increases the effect of radiotherapy on the tumors. And then, of course, you have other applications that you can couple to the shells of the bubbles, drugs, for example, in the case of tumors, anti-angiogenic drugs, or chemotherapy treatments. I wrap up my presentation and I do a special acknowledgement to Francesco, Claudia, and Lara, which are our very professionals and specialists on doing ultrasound at CNREFC. Thank you.